moments of quiet, we will begin. Welcome to VLANJ Voices, an educational speaker series that offers education, tools, and resources to help manage tasks in your everyday life. Our speakers in this series bring new voices representing diverse backgrounds, approaches to learning, as well as sharing information about opportunities available in your community. Joining us this evening, we welcome Dr. Jonathan Fishbein. Before I formally introduce Dr. Fishbein, I would like to share his bio with you. Dr. Jonathan Fishbein is an optometrist currently practicing at the Low Vision Center of Central New Jersey in North Brunswick, New Jersey. He received his optometry degree from the New England College of Optometry in 1997. He became interested in low vision during his exposure to this specialty during his third and fourth year clinical rotations. This led him to completing a one-year residency at the Feinblum Low Vision Center at Pennsylvania College of Optometry in 1998. In 2001, Dr. Fishbein, along with his wife, Bethany, also an optometrist, started the Low Vision Center. The clinic was initially located within New Jersey.
You move the chair over, please.
Since 2010 has been located as a specialty practice within the Fishbein's private practice, Somerset Eye Care, also founded in 2001. For 22 years, the Low Vision Center has provided low vision exams and services to patients from New Jersey, New York, Pennsylvania, and beyond. The practice's philosophy is a goal-based low vision exam, meaning that patients' functional needs are what guide the evaluation of glasses and devices. Before we begin our presentation, I would like to review our Zoom protocol. For those of you who dialed in, the raise your hand feature is *9. *6 will mute and unmute you, giving you the opportunity to ask your question. Using a computer, Alt-Y will raise your hand, Alt-A, mute and unmute command. If you're using a Mac, use the Option +Y, the keyboard shortcut to raise or lower your hand, Alt+A to mute and unmute yourself. Using the Zoom app on the iPad, move to the top right, select the More option, and flick down to the raise hand. On the iPhone, this feature is located at the bottom of the screen on the right-hand side. And now we welcome Dr. Jonathan Fishbein. Welcome, Dr. Jonathan.
Thank you guys so much for having me. This is really, Elsa and Linda, a true honor to be invited to give this talk. And I'm hoping for all the attendees that what I'm going to share today will be worth your time, spending your time here watching and listening. And absolutely, I'm open to questions or comments or anything else. I will say that I just got a big education on Zoom because I didn't know about all these shortcut features. I usually try using my desktop. I will share that in terms of lecturing, this is the first time I've given a talk since before the pandemic. And obviously, in that case, also the first time that I'm doing a lecture on Zoom. So it's a bit of a unique experience for me as well to be presenting in this way. So bear with me. I do have some slides, but really I'm mostly going to be talking. I know that Elsa had shared with me that the attendees have various levels of having no vision problems to, all different ranges of vision impairment and low vision. So if there's something on a slide that you can't see, I'm mostly just putting it up there somewhat for my own purposes so that I kind of keep track of my notes because I'm used to kind of having my notes on a lectern in front of me when I'm talking. So this is, like I said earlier, a little bit of a unique situation for me too. As we progress through the pandemic and beyond. So thank you for the introduction again. So, my wife and I graduated 25 years ago, and a big part of our professional life has been dealing with low vision. My wife, even before optometry school, she knew that she wanted to practice low vision. She had been a counselor and swim director at Camp Marcella up in Rockaway, New Jersey. And our office still goes there once every summer, with a couple breaks during the pandemic to do ice cream parties with the visually impaired kids there who are fortunate to get kind of a normal summer camp experience. And that's been a true passion of hers. And, that kind of her passion for the low vision led me to choose to do a low vision internship when I was in optometry school in my third year. And I discovered that, hey, this is really a unique way of practicing and a unique patient base, and really led me to decide that that was something that I would specialize in as well. So after I graduated, I did the 1-year residency in Philadelphia, which was really pretty amazing in terms of the variety of patients that I got to see and help, and work with more experienced mentors and other practitioners. So, as Linda said, after we were both finished with our schooling, we worked in a couple of private practices individually, and then wound up opening our own office in 2001, along with the Low Vision Center, starting off seeing patients in the offices of New Jersey Retina, and then eventually just kind of folding that in with our private practice, where we see everyone in one location. So we have 3 doctors now that are doing low vision, myself, Dr. Ansel, and Dr. Collin. Both of the 2 associates have very similar experiences in terms of their education. And the 3 of us make, I think, a nice team to have similar mindsets in terms of how we take care of our patients and their families, both in terms of so-called regular eye care, but also with the low vision community. So in today's lecture, I wanted just to kind of go through, 2 or 3 different little sections. And what I'll do is I'll stop for questions along the way. And I guess Linda or Elsa will kind of help navigate that as questions pop up, either in the chat room or otherwise, if someone speaks up. So hold any verbal questions or unmuting rather, until I kind of give the go ahead once I'm finished this section, just so that I can keep on track. So just a little bit, I'll talk a little bit about demographics, a little bit about eye anatomy, and some of the different conditions that cause low vision. And then lastly, the bulk of the talk will be, what makes a low vision exam different than a regular eye exam or a retinal exam or a visit with, any of the ophthalmology specialists. What just a little bit more about specific with low vision care and low vision optometry. So, I'm not going to get too much into numbers and figures, but we know that, low vision population is going to continue to grow. This is going to be despite all the advances in medicine and clinical trials and other advances that we hear about almost on a weekly or at least monthly basis of new treatments that are out there. Despite all of that, we know just somewhat because of the demographics of the baby boomer population, that those numbers are going to increase. And it's unfortunate that there's not more practitioners like me, because not just New Jersey, but really, the country and probably the world really needs more doctors that are familiar with helping patients that wind up having visual impairment due to disease. So I think I was reading an article yesterday. I write this down. It said of those patients older than 71, 28% of those patients have some form of visual impairment, which is a pretty remarkable number, and that's over age 71. So again, those numbers we predict are going to be increasing. Macular degeneration kind of takes the lead on that. So before I start going into the eye conditions, I'll do a quick run through, or I'll kind of use a run through of the anatomy to guide us into discussing some of the conditions. Once I'm done going through that, again, I'll let Linda know and I'll say, okay, let's take some questions. So, if we're looking at the diagram here, I have an eye anatomy picture up on the screen. The left side of the screen is the front of the eye, and the right side of the screen is the back of the eye. So it doesn't label it here, but the foremost structure is the eyelids and the eyelashes. Those don't really typically cause visual disease problems, but they serve more as protective from foreign bodies and things like that to protect the inner surfaces of the eye. The next structure in is labeled as the cornea. That's kind of the clear window on the front surface of the eyes. A lot of corneal diseases that cause visual impairments are actually often helped either by surgery on the cornea itself or with special types of contact lenses, often called gas permeable lenses, or more recently, they are scleral lenses, which are larger lenses that are able to restore vision for people that have corneal disease or degeneration. You might have heard a condition called keratoconus, but also other conditions either from injury or other reasons that happen deeper in the eye can also affect the corneal health. Moving in from the cornea, or adjacent to the cornea rather, is the conjunctiva. Most of you have heard a condition called conjunctivitis, which is just a very generic term for red eye or pink eye. Those typically do not progress to causing any problems. Those are more acute problems that are typically treated with drops or sometimes oral medications, antibiotics or steroids if they're very severe. Behind the cornea is a structure called the iris. The iris is the colored part of your eye. So most of us, it's brown, blue, or green, or hazel shades in that area. People can get tumors or other diseases in the iris, or the iris can be misshapen, which can cause problems with light sensitivity and distortion of vision. Within the iris is the pupil. The pupil isn't really a structure. It is actually simply a hole within the iris through which light passes through and enters into the lens and later on into the retina. So that brings us to the lens of the eye. So, the first condition that we'll talk about is cataract. So a cataract by definition is any clouding within the lens. I will often tell my patients that I almost don't consider cataracts a disease. It is really a natural consequence of aging. It's not unlike having wrinkles in our skin. I will joke that, things that are sure in life, if we live long enough, are taxes, wrinkles, cataracts, and death. Sometimes that gets a chuckle, sometimes not so much. But in any event, all of us will get cataracts if we live long enough. Most patients that I see, by the time they are 85 or 90, cataracts have progressed to a point where they need to be removed. That has become a relatively simple surgery, and I believe that it is still the most commonly performed surgery in the United States is cataract surgery. It's relatively simple, and as long as there's not other diseases going on, is usually very successful in restoring vision. Essentially, with age, the lens of the eye, which is normally clear crystal-like, becomes clouded yellow with various opacities throughout it, and that causes blurred vision, that causes light sensitivity, that causes difficulty with driving, especially at nighttime, but also with reading, and generally progresses slowly, takes anywhere, usually starts for most of us around a late 50s into the mid 60s, and will take anywhere from 10 to 15 years to progress to a point where it's significant enough that it's causing issues. I'm just going to switch slides for a second. Here I have two images. On the left side is so-called normal eye, and we see light entering through the cornea, through the pupil, through the lens, and then reaching a very fine focal point on the retina. And the image on the right shows, the top image shows kind of a cloudiness that you see through the pupil. And the bottom image just is a diagram of what happens with light as it enters the eye through a cataract lens, which shows that the light, instead of coming to a focal point on the back of the eye, becomes very scattered, and that results in an individual just not seeing things as sharply. Even with the best glasses, they're still just not going to see sharp. So a lot of my patients, when I'm following them for cataracts, we'll have a discussion and they will say, well, when do you think it's ready? This is maybe a patient that still has 20/20 vision, but I'm telling them that they have some early signs. And my response is usually, well, know you're ready when you come into me and you say, hey, doc, I'm having trouble driving or I'm having trouble reading. And when I say to you, well, I can't, at this point, I cannot make that any better with new glasses. And as long as there's nothing else affecting the eyes, the other eye conditions that we'll discuss in a few minutes, then it's time to have them go see a cataract surgeon. A lot of times people will come in and they'll have early cataracts, and that causes vision changes, but those are changes that I can improve on with a new glasses prescription. So those patients, we would hold off on doing surgery. We don't do surgery if it's not necessary. I'm going to go back to the initial diagram. And so behind the lens is this solution called the vitreous body. It's really a gel. It's basically the gel that fills the inside of the eye. It's clear because if it was full of blood vessels, it would cause blurry vision. You wouldn't be able to see through those blood vessels. So it's a clear fluid that provides two things. One, it provides some nutrients to the internal eyeball, but it also allows the eyeball to maintain its shape and form. If there was no fluid there, the eye would collapse. So, that's kind of how the eye is designed to maintain its integrity. What can happen in some people with the vitreous is either due to trauma or other eye diseases, there can be bleeding or hemorrhaging that happens. In which case, oftentimes the vitreous is removed. Basically, they suck out the fluid and replace it with a silicone fluid. The vitreous in patients without disease will still cause some issues that are often referred to as floaters. Floaters are basically occurring when bits of the vitreous clump together and form, and through those, because of those clumps, will cause a shadow or kind of an amoeba-like floater, basically, is still the best way to describe it, that moves in the patient's vision. Typically, we don't do anything about those. Some more aggressive surgeons will advocate blasting those with a laser. If you are under, say, age 65, you might remember a video game called Asteroids. And if you remember with that video game, you would shoot a big asteroid and it would create 1,000 smaller ones. So it's kind of akin to that. And again, at least in New Jersey, perhaps because there's so many lawyers, there's not a lot of retinal surgeons, if any, that are really advocating that type of treatment. There are some in other states, and it's a little bit more prominent in Europe. That might become something down the road that becomes more prominent here. But for now, when people have floaters, as long as they're not really dramatically affecting the vision, we just kind of have patients deal with them. So we get back now into the back of the eye, and here's where really the crux and majority of eye conditions happen that will affect the vision. So let me just talk first, just briefly. I'm not going to go into too much detail, but macular degeneration, as I said before, is really the kind of the number one condition that I see in my office for low vision care. And again, they feel like this is something that, unfortunately, despite all the clinical trials and medications and treatments and improvements in treatment, they still feel that this is really going to be something that a lot of a bigger percentage of our population moving forward is going to be dealing with. So the image on the left, unlike the diagram, this is kind of showing a head-on image. You imagine that you're looking directly through someone's pupil. You'd be seeing this in the back of their eye, which is what we see as eye doctors when we either take a picture of your eye or look at your eye through the microscope in the office. Again, if you are a visual person, you can see what I'm doing. My mouse right now is overlying the optic nerve. And to the left of that, the kind of the darker area that's shaded is called the macula. So the macula is the part of the retina where there's the highest concentration of cones and the highest concentration of pigment. That's the part of the eye that we use for our most detailed vision. So things like reading and driving and fine detailed work up close, that's all happening through that most central part of the eye. The image in the middle is showing a very similar appearance, but we can see there's these opaque areas here. Those are called drusen. And drusen are basically accumulation of waste deposit from the retina's metabolism. So what does that mean? Usually our bodies are constantly regenerating cells throughout the day, throughout the minute, and usually cells that die off naturally and cells come back and replace them. And those dead cells will just get washed away through the bloodstream and otherwise, or resorb back into the tissue. For whatever reason, in macular degeneration, those waste deposits clump together and form what are called drusen. Clinically, we see as kind of these white spots, and those will, depending where they are, will cause various levels of degeneration and decreases in vision. So when there's a few of them, oftentimes the patient isn't even aware there's an issue until they come in and get an eye exam and perhaps have a photograph taken, or even without a photograph, the doctor can see those forming and can talk to the patient about ways that we can hopefully slow that down so that it doesn't progress to a more severe form. Typically, that's done with either vitamin therapy. Many of you, I'm sure, have heard of Preservision, which is the brand name product of something called AREDS. AREDS vitamins. There's many other companies that make a similar product. AREDS stands for Age-Related Eye Disease Study. And that was a study that was completed, I believe, stage 1 around 2003 or 2004. And then stage 2 was completed, give or take, around 2010. And those basically came up with a formulation of different vitamins that were deemed to help slow this down in certain patients. So we talk about vitamins, but nutritionally, colorful foods, meaning leafy green vegetables and colorful fruits also have nutrients rather, that are specific to that part of the eye. So moving on, unfortunately, some people, even with their best efforts, also UV protection is the other thing that I didn't mention, meaning wearing sunglasses anytime you're outside, UV protective sunglasses, even on cloudy or overcast days. That's what we know to try to prevent it from getting worse. There is only just in the last few weeks, FDA approval for a new medication, the first medication that they feel may be able to help some patients with dry macular degeneration, prevent them. And that's the first of its kind. It's recently approved, and some of the retinal clinics are just now starting to do treatments. It's approved by the FDA, but most insurances, I believe at this point, have not yet decided that they're covering it. I think it's an injection, so it's not without risk, and it's not 100% guaranteed to slow things down, but that is something that would be discussed with your retinal specialist if you have this condition and if you see one. That's called Sinofear, by the way. And again, that's brand new, hot off the presses. The retinal community is very excited for this development and are very gung-ho for the opportunity to hopefully save some patients' vision. The retinal community and everyone in the eye community for that matter. Lastly, on this slide to the right side is wet macular degeneration, and we can see it's a similar diagram, but we've got this kind of red blotch in the middle. Frankly, it doesn't typically look that way clinically, but we see that sometimes. More frequently, it's a lot more subtle. There's bleeding or hemorrhaging that's happening underneath the surface. Many times it's not visible on the surface, and we detect it by other means, a device called an OCT or tomography of the internal layers of the retina that let us see leakage. So when they say wet, what they mean is that there's leakage of fluid. That fluid is typically blood, and that's coming because there's abnormal blood vessel growth in addition to the drusen that I mentioned earlier. And so that makes up about 10 to 20% of macular degeneration patients, while dry makes up 80%. The bad news with wet macular degeneration is that typically people that have that have more devastating vision loss. The so-called good news, if you want to put a silver lining on it, is that it's the only condition that has a treatment. Ignoring what I said before about this new one for dry. But until a month ago, only wet macular degeneration had a true treatment. And that's been done with basically 3 different medications over the last 5 to 10 years. Eylea, Avastin, and Lucentis are 3 different types of injected medications. The trade-off is that while we hope, and the retinal doctors that are doing these treatments hope that that can slow down the condition, you need to have an injection in your eye, typically anywhere from every 4 to 12 weeks, depending on how your eye is responding. So, that's kind of macular degeneration in a quick nutshell. I'm sure there's questions coming up, but I'm going to move on and just finish the eye anatomy and review of different conditions. So that's the primary retinal condition. I'm going to just move over to the retina. Oh, and I apologize, this slide is very small, but I will describe it. So what I'm going to describe next is glaucoma. So glaucoma is basically an optic nerve disease. And what happens with glaucoma is the optic nerve is the very small structure in the back of the retina. Think of it like a tube. When we look at the optic nerve, for those of you that can see, it's this circular structure that I'm outlining with my mouse in the back of the retina. And it's basically what I'm seeing here is the end of a tube that stretches from behind the eye into the brain and transmits all of the visual information that's coming in through the retina. So people, whether they have what's called high pressure or normal pressure, people with glaucoma will develop damage to that structure, the optic nerve, basically because the blood vessels are just not getting enough oxygen to keep the nerve healthy. When that happens, regardless of what the pressure is, if it's elevated pressure, there are two ways that we use to treat that. One is with drops that are designed either to make the front surface of the eye produce less fluid or to open up the drainage of how the fluid drains out through the front of the eye. The goal of this is to release pressure that is pushing on the blood vessels that feed into the optic nerve so that the nerve remains as well nourished as possible, either to prevent disease to the nerve or to hopefully stop damage to the nerve that's already taken place. So again, for those that can see, the image on the left shows a nice kind of pink and healthy structure here, and the image on the right has this kind of pale appearance, which indicates that that pink healthy optic nerve has been damaged. Unfortunately, they also call this condition the thief that steals sight in the night. And the reason that it's termed that way is because it is very asymptomatic, meaning when we think about conditions that affect the eye and things that might bring a patient in to get an eye exam or see their eye doctor urgently, it is typically things that will cause either pain in the eye or blurry vision. And this, until a very late stage, causes neither of those. I'll backtrack a second and just say there is one form of glaucoma that does cause pretty severe pain, but that makes up maybe 10%, and that's called closed angle glaucoma. The end result is the same, but the presentation's a little bit different. It's a little bit off topic, so I'm not going to delve too much into that. But an average open angle glaucoma patient can go years and often even decades before they become truly symptomatic. So much of eye care is designed to pick this up at an early stage and be able to initiate treatment at an early stage, typically with eye drops, but more frequently they're doing surgical and laser procedures as a first-line therapy. More advanced cases will need more advanced surgeries and stents and things like that to keep the eye pressure in control. So I mentioned before, I got sidetracked a little bit, but my most scary patients are patients who present to me for an eye exam and the technician does their history and comes out and says, yeah, they're 60 years old. They said the last eye exam they ever had was when they were in high school. And I'm always just very anxious thinking, oh boy, I hope this isn't one of those patients that's had glaucoma building up over 30 years and had no clue. And unfortunately, I've had many of those over the years. And it's sad when it's something that could have been prevented, but more frequently, an average patient is someone that we have picked up early stages and we're either monitoring it to make sure it's not developing into frank glaucoma or actively treating it. And typically, patients with glaucoma will have a unique situation because they actually see fairly well on an eye chart. They're looking at black and white letters, either on the distance eye chart or on a reading chart. However, many times they are missing parts of their peripheral vision and sometimes are not even aware of that until we test it, or have very vague symptoms that they can't really put into words about their vision. And many times also what's going on is that their vision is generally washed out. They lose a lot of contrast, meaning that as I said earlier, if they're looking at a black and white eye chart, they see it very well. But if they are looking at something like a newspaper that has, dark gray print on a light gray background, or things on the computer or printed material that maybe is, black ink on a navy blue background, things that require increased contrast, they have a lot of trouble with. And that's kind of one of the things that happens with glaucoma. It's not so much the acuity as other factors. Of course, once it becomes very advanced, even the acuity hits. And unfortunately, many of these patients, even with the best treatment, will become legally blind and be pretty severely impaired when that happens, because they not only lose their peripheral vision, but they will also lose their central vision. That's contrasted with macular degeneration, by the way, where those patients very rarely go completely blind. Most of them will still have, even in the most advanced cases, will still have their peripheral vision intact and still be able to see shapes and forms, even if they do not have their central vision remaining. All right, a couple more minutes on anatomy. This is a little bit larger photograph here. So here we're talking about diabetes. All of these, for those that can see it, all of these, this is a picture of the retina. On the left side is the optic nerve, and in the middle, this is a left eye. In the middle is the macula, and the red lines that we see are the blood vessels, but all these red blotches are bleeding from diabetes. And that happens when the sugar is just not well controlled on a daily basis, and becomes very much more prominent even in people with diabetes who are well controlled. Once they've had that condition for 15 or 20 years, even with good control, we start to see signs like this. But people who have had it for a shorter period of time, we will also see this if they are not well controlled, meaning if their A1C measurements are 8 to 10 or higher, and when their blood sugar numbers are typically 150 and above. So the reason that people with diabetes will struggle with their vision is because in that macular area, there will be swelling, bleeding, and leakage of fluid that happens there. And that causes pretty severe distortion. And that typically will be happening in both eyes, not usually the same in both eyes, but typically it's a bilateral condition because it's coming from a systemic reason. When something is systemic like diabetes, that will typically affect both eyes somewhat equally, but usually not 100% symmetrically, meaning both eyes are not usually identical. So prevention and treatment is just getting the sugar levels stable as best we can under the care of primary doctors and endocrinologists and nutritionists. Medically, the only way to treat this is that when there is bleeding, they're either using laser treatment or using one of the same injected medications that's used for people with wet macular degeneration, because essentially this is happening because there's bleeding from abnormal and small fragile blood vessels. I'm going to just move on here. So the optic nerve, I'm just going to go back quickly to the anatomy. So again, this is showing the back of the eye. We talked about the retinal conditions. We talked about the optic nerve in the back of the eye, this yellow area, and we can see it's a tube hanging off to the right of the retina. And so we talked about glaucoma, which affects the optic nerve, but the other thing that can affect the optic nerve is you can have what we generically will call a stroke in the eye. So, basically like an optic neuropathy. A stroke happens when there's a clot or other blockage in the blood vessel. When you have a stroke in the brain, we all know what some of the symptoms of that are. But when it happens in the eye, it's a more unique situation because it may not even affect the central vision, although it certainly can. But just as frequently, the central vision can remain intact, but the individual will lose part of their visual field. because this is affecting the eye at a deeper level, really where the eye is connecting with the brain. So this is an image here of someone's visual field where their top vision is fine, but you see this grayed out area on the right eye and a grayed out area on the bottom on the left eye. So an individual like this, when they look straight ahead or up, are going to be seeing fine, but when they're walking, they're going to be more likely to trip over things. And when they're trying to read, they're going to have a much more difficult time, because essentially they're looking down into their blind spot and are going to struggle with that. Depending again on exactly where the stroke might be happening in the optic nerve, they can have the opposite situation where it's affecting the top part of their vision. So these are patients that won't have trouble necessarily with walking, but might be bumping their heads onto cabinets and other things because they can't see things that are above their line of sight. So that's kind of a subvariant. We don't see that too often. Stroke treatments have improved a lot, and but we do see things like this in various forms, not infrequently. So let me just consult my notes real quick. Okay, so I don't have pictures for some of the other conditions, but childhood conditions or inherited conditions include something called Stargardt's. Stargardt's is a macular condition. It used to be called juvenile macular degeneration, to contrast it with age-related macular degeneration. It basically has a very similar a very similar appearance, in that the macular tissue itself is distorted and degenerated. And that results in intact, in other words, the peripheral vision remains really good. However, their central vision is impaired. This typically will start to affect patients when they're in their teenage years or at the latest at the early 20s. But most of the time we start to see this somewhere after puberty. These patients tend to be pretty highly functioning, although they do need help going through their school years in terms of visual aids and accommodations, because they will read a little bit slower and have other limitations. Their vision is usually around in the 20/70 to 2200 range, depending on the specifics of their condition. They remain highly functional, and in our clinic, we've seen several of these patients. Off the top of my head, I can think of 5 or 6 of them who have actually gone through med school. These people are not becoming surgeons necessarily, but off the top of my head, I'm thinking of 2, one who became a psychiatrist, and another one who is in med school now, who is planning to become a pediatrician. And again, there are certain limitations, like the one that I saw recently. We've been following her for some time, and so every new year in school, I need to draft a letter for her, because there are certain things she's just not going to be able to do, certain labs, and that's not someone who you would want necessarily assisting a surgeon, but you can still be a doctor without being a surgeon. So they tend to be, just like everyone else, obviously, functioning, and academic and other achievements are going to be individual, but this does not necessarily need to be something that limits a person's ability. Similarly, albinism is something that results in, obviously it's an inherited condition, and results in a much thinner and paler macular tissue. So those patients often have eyes that have very high prescriptions, but also just generally do not achieve perfect acuity. Usually they're closer to 20/50 to 2100. Many of them are still able to drive or wear special glasses for driving. And typically they're very light sensitive, which goes along with a lack of pigment inherent in that condition. Other conditions that people will develop at a little bit later age is something called retinitis pigmentosa. With that condition, typically starts to affect people in their 20s and early 30s into their 40s and 50s and 60s, and will unfortunately eventually cause near complete blindness. But in early stages, patients with this, like glaucoma, will maintain excellent distance vision. However, they have what's called tunnel vision, meaning that their peripheral vision gets cut off. This affects the rods in the eyes, which are responsible for peripheral vision. And night vision is the other thing that this typically will affect. So those patients, everyone has trouble at nighttime, of course, especially in New Jersey, where you either have poorly lit roads and or SUVs or even sedans whose lights these days feel blinding even to people with completely normal vision. But these patients will have more dramatic and very debilitating night vision issues, especially moving from a light room to a dark area and just generally being outside at night. They really feel like it's pitch dark. So they maintain kind of normal vision typically until they're in their 40s or 50s, and then they start to have other problems like cataracts. And as it progresses more centrally, they start to become a little bit more visually impaired in a traditional sense. Other conditions include various forms of retinopathy related to being born prematurely. Again, these are usually, kids that have blindness from birth, and other optic nerve diseases similarly that affect usually, kids are born that way, either through a birth defect or other types of trauma. Two other optic nerve conditions that can affect the eyes are more from a systemic standpoint. First is MS and also Parkinson's, MS meaning multiple sclerosis. Both of those will affect the optic nerve, sometimes slowly over time, but other times can kind of come out of nowhere. And sometimes it's actually with MS. Sometimes that is actually diagnosed after a person starts having a vision problem. And that will cause more like a shadow in the vision and a blind spot that's not necessarily right in the middle of the vision, kind of off to the side a bit, but something that the patient is aware of, sometimes with some pain behind the eye. Fortunately, most of those patients, that's something that will bring them into the office, and hopefully we get them care in a quick manner and get their MS under control, to hopefully prevent further outbreaks of what's called optic neuritis. So with that, before I move on to talking a little bit more about low vision exam specifically and some of the things that make that unique, I'll let Linda open up any questions, and happy to answer anything. I think I'm going a little overtime here, but I'll let you guys be the guide on that.
That's okay. It's great information. Thank you so much. So we want to open up to questions. I have two hands that are raised. So if you're calling in, listen for the last four digits of your phone number. So 8221, you've had your hand raised for a while. So you can unmute yourself and then ask your question.
I'm sorry, I don't have a question. That was a mistake.
Okay. Oh, hello, and thank you. Okay, next up we have Michelle.
Yes, my question is, a lot of times when dealing with these issues that you've talked about, people such as me, become very photosensitive. Why is that?
So that can be for a variety of reasons, depending on exactly where the condition is happening. But basically, the retina, if it's happening on the front of the eye, then oftentimes it's related to that. So our eyes become sensitive if there's irritation on the front of the eye, or if you've had treatments on the iris or on the lens. Many times that will cause your pupil to not respond the way that it should to bright lights. So sometimes that can be a source of light sensitivity. But when it's happening in the retina, when there's disease there, what we want to keep in mind is that the retina is really a skin tissue in essence.
Mhm.
And with the skin tissue, there's pigment. And so when there's disease in the retina and pigment is either damaged or lost,
Mhm.
the pigment is what will oftentimes absorb bright light. And so that can be part of why you become a patient that's visually impaired becomes more light sensitive.
Well, in my case, I suffered in one eye trauma, and
Mhm.
I had a choroid detachment, but I
Okay.
healed miraculously from it.
Yeah.
And then my problem is in the front of the eye, keratoconus, and I've had DSAKs,
Yeah.
PK, PKs, and I've had lens implants in both eyes. Now
Okay.
I'm just left with vision in the left eye. And I just thought about something you said. I was very, upset about it before, and I kind of tried to push it out my mind, but I was hit in the eye by a doctor many years ago, after my first corneal transplant, and he hit me
Right.
in the pupil and
Oh, wow.
with a laser, and it permanently opened the pupil in that eye. And
Yeah.
but just recently, it seems like I've become even more photosensitive. I've just had my last surgery. I had a lens implant and a DSAK on that eye, and it just seems like I'm even more photosensitive now, and it's very, very bothersome.
Yeah.
And I just wondered why it was becoming so. Um, and I thought about it, that that I know that pupil has been permanently opened, but it just seems like I'm more sensitive lately since I've
So,
got a lens implant in the
yeah.
last corneal transplant.
So sometimes what happens with what you're describing
Mhm.
can be that, with the lens implant and even with having, a corneal procedure,
Uh-huh.
those things may counterintuitively be giving you better acuity and more
Hmm.
sharpness.
Yes.
But when you have cataracts taken out and a lens implant,
Hmm.
you're removing a filter for some brightness. And when
Yeah.
you get a fresh lens put in,
Hmm.
suddenly you can become more light sensitive.
Wow.
So that could be part of it. So sometimes, in our office with those patients, we'll talk about having glasses that are permanently tinted, not dark, but
Yeah.
having like an indoor tint,
Oh
as
yeah,
well
like
as
cocoons,
a
you mean?
darker outdoor tint.
Like the cocoons and the what's the other ones? I've got
Yeah,
some cocoons
yeah. But having ones that you can still function indoors, not
and
necessarily
indoors.
like,
Yeah, I
yeah.
need those. Yeah,
Yeah, so
yeah.
sometimes we'll do that. And then you
Mhm.
mentioned, with the corneal condition, sometimes having, one of these special contact lenses,
Uh-huh.
called scleral lenses can sometimes, once your
Yeah.
eye's healed, that can be an option as well.
Oh, that'll be fun because I've got
Yeah.
little teeny tiny eyes, getting them in and out.
Yeah, those have been pretty amazing. I personally don't, just because I didn't receive training when I was in school, and
Uh-huh.
they're really in the last 10 years. But two of the associates in our office
Mhm.
are really been very successful with that. And it's pretty amazing for
Yeah.
people with corneal disease being able to give them
Yes. Yeah.
their
So,
sharpness back, but also sometimes addressing things. But also,
okay.
the other thing with light sensitivity
Mhm.
can be if the cornea is very dry and irritated, that will also cause
Oh,
lights.
yeah. Oh, really? Thank you for that one, because I do have an autoimmune disorder that
Yeah,
dries out the
sure.
tear. I can't
Yeah,
produce enough tears
yeah,
and saliva.
that can be a
Yeah.
huge source for sure.
Yeah. Okay. Maybe
Okay.
that's it. Okay. Thank you so much.
Of course, and I think there is
Mhm.
one other question before we move on.
There is Tracy. Hi, Tracy.
Oh, unmute yourself or,
She is unmuted, but we can't hear her.
oh no.
Hear me now?
Oh, yeah, we got you.
No, turn it up a little
Hello?
bit.
Oh boy, let's see.
I can hear her.
Better.
Oh, unmute again.
Now you have to unmute.
There you go.
There you go.
Can you hear me now?
Yes.
Yes.
Hi, Tracy.
Good,
Can you hear
Tracy.
us?
Oh, you muted yourself again, Tracy.
I think she wasn't able to hear us, so maybe she's trying
Yeah,
to.
I'm getting that thought.
Can she maybe type a question into the chat box? Is that an option?
It is an option. Oh, there you go. Tracy, you're unmuted.
Can you hear us? No? Can you hear us, Tracy?
I think she's having, Tracy, you work on those technical difficulties, and we'll take Linda's question for now, but don't go away, Tracy. Okay, Linda? You can
Linda.
unmute yourself, Linda.
Okay, can you hear me?
Yeah, we got you, Linda.
Okay, hi. Hi, doctor. Thanks for
How are
this.
you?
Okay, thanks for this very informative lecture. I've been dealing with problems all my life, but so I'm low vision and everything, legally blind. But the question I have specifically is, what is with the resource in terms of when you go into a store and you're trying to read when you go into the shop, right, and you're trying to read the amount of money that you're spending on food, et cetera, and you want to be able to see it clearly by yourself without getting any assistance from anybody. What do
Mhm.
without spending like $1 million on something, what do you think is the best device that I could get to do this?
So it really depends on the individual, and I will be speaking shortly about more specific about some low vision devices, but depending on what your level of vision is, you know, either you know, a magnifier that you can hold in your hand, or an electronic magnifier, or if visually it's not something that either of those is an option, then I am going to talk later just briefly. There's a device called ORCAM.
Okay, yeah, I read about.
ORCAM.
Right.
It essentially will read material to you.
Isn't that quite expensive, doctor?
It is expensive, yeah.
Yeah, I know. Okay, I got you.
I had heard that we're not providers with Commission for the Blind, but I had heard that for some patients, they might be covering that. Or I know
Really?
that they're looking into it. Don't quote me on that, please, but
Right, I know.
again, because
It's
I'm not a
something-
direct provider with
Yeah,
them.
Yeah, I
But
know.
if you are a
expensive.
client, it's probably worth asking your caseworker if that's something that could be considered for you.
Right. And you
Tracy,
think,
we got, yeah, go ahead.
you think magnifiers would be helpful and just to
Oh,
hold on?
it's so, Linda, it's so dependent on the individual. So without
Yes.
knowing your vision and the details,
Okay.
you know, I tell anyone, if you haven't had a low vision exam, then seek one out, and that's really the best way to know.
Okay.
I do encourage my patients get an exam with a low vision doctor, because you can, you know, try to order stuff online yourself, and you're not always going to get what's
Right.
necessarily going to
Okay.
be the right thing.
Got it.
And
Thank
then
you.
some people will think, oh, I tried magnifiers, they don't work, but you might not have tried the right thing.
Right, exactly. Okay, thank you, sir.
Of course, my pleasure. Tracy,
Thank
how
you,
are we doing?
Linda.
Oh, I see you talking, but we still can't hear you.
Yeah, and it's
May
so
I ask a
strange.
question?
Yeah.
Yes.
Oh,
Can I ask? I'm sorry, I don't know. I have no idea how to do this. Can you
Okay,
hear me?
go ahead, Bobby.
Okay, all right. So basically I have exfoliation syndrome, which,
Yeah.
you know, we haven't
Form of
touched
glaucoma.
upon.
yeah.
Okay,
It's
but
a form of glaucoma for those listening.
yeah, but it's really coming from systemic, systemic issues that are then affecting the eyes. Of course,
Yes.
all glaucoma probably is also based on, constitutional issues, but we don't know about it as yet. But I read recently about glasses that you can wear that actually bring the pressure down through wearing these glasses. Have you heard
I've
about
not
that?
heard of, I'll be honest, I have not heard of that.
Ah,
I
okay.
heard of glasses being able to bring the eye
Mhm.
pressure down.
Okay,
I don't know how that would work because the eye pressure is something that's coming from the internal part of the eye.
hmm
They are working on contact lenses that will be infused with the medication that's used for glaucoma eye drops. I don't know if that's maybe what you're thinking of.
no, no,
But
something else.
but glasses to bring the pressure down, I don't know how that would
Mhm.
function. So I've not heard of that. Thank you.
The reason I asked the question is that I am one of these hyper allergenic, people. I'm allergic to the eye drops. I had
Yeah,
a bad reaction to the laser. I'm
yeah,
basically going blind, at least in one eye, because this is what's happening.
yeah.
I have no recourse. So,
Yeah. I mean, if drops and laser aren't doing it, then I don't know if they've thought about more invasive surgery, but that's something
but I'm allergic to what you need. What do you to bring down? What is it called? Steroids. Yes.
right.
Normally you have to have steroids when you're taking the surgery, and I'm allergic to steroids.
Yeah.
So
Oh
I'm
boy.
really in a very
Yeah.
difficult situation here.
That's tough. Are you seeing a glaucoma specialist?
Oh, yes, a
Okay.
couple of them, but it's a very difficult. I am going blind, and then I can't be helped. And I'm
No, I'm
curious
sorry to hear
about,
that.
thank you, but I'm curious about glaucoma. The origin of glaucoma as a systemic entity, has that ever been studied?
It's certainly something that's being looked at in terms of both genetics and systemic. One of the things that I tell all of my patients when they, not just my low vision patients, but when they ask me, what can I do to preserve my eye health in general? And what I tell my patients is anything that's heart healthy is also eye healthy. The optic nerve, so for those, if you look back at what I have shared here, but the optic nerve, this part of the eye here that is at the back of the eye with the yellow tube. So in real life, the size of that is about the size of a pinhead. If that's the size of a pinhead, think how small and fragile these blood vessels are that feed it. So anything that helps with your overall circulation is going to help preserve your eyes and your vision. Beyond circulation issues, there can certainly be inflammatory conditions that might not be affecting the body in other dramatic ways. But there's a lot we don't know about glaucoma. You're right. We know, there's been a lot of advances in treatment and early diagnosis. But there's still a lot of mysteries about why it happens in the first place.
Thank you very
Of
much.
course. My pleasure.
Dr. Fishbein, I'm going to read Tracy's question. She wrote it. in chat.
Yay.
Okay, this is from Tracy. I have Stargardt's for 12 years now. My question is about ocular migraines. Should I be concerned about these painless light interruptions?
How old are you, Tracy? Want to hold up your fingers? 46?
No.
Oh, 50. Okay, I didn't see your thumb. 56. Okay. So ocular migraines can be common. My threshold for being concerned about ocular migraines is if you're over 50 and if you never had them before and then suddenly started getting them. And honestly, usually when that's the case, it's not specific to the eye. Once we rule out that, I assume when you're seeing these funny lights and shapes in your vision, do they usually, I assume that they're lasting 20 to 30 minutes and then they're going away?
They're like 3 seconds or a half a second. So they're like, they
okay.
come when I feel like a moment of an anxiety, a thought of anxiety, like, oh my gosh, I have to go to the store and I don't have a ride. then it'll just pop up in my eyes, and it'll be like a small light, like a laser in the
Okay.
shape of my eye.
Okay. And you're not getting headaches afterwards?
Not
and
at all.
That's lasting just like a second or two?
Yeah.
And then it goes away, or it's lasting a second or two every minute for 20
It goes
minutes?
right away. As soon as the picture of the eye shapes
Okay.
complete, then it's gone.
That I would be a little bit less concerned about, but you know, in terms of a source for it, sometimes when we're an adult and there's a new visual impairment, you know, it can be something, even though 12 years isn't necessarily new, but it can be something that your brain is almost still adjusting to at times and can give these kind of funny images.
Yeah.
But certainly, if that's relatively new, you know, within the last few months, or certainly if it's, you know, something along those lines, certainly worth checking with your eye doctor and
Okay.
just making sure that there's nothing happening
Mhm.
aside from the Stargardts.
Okay, thank you.
That there's nothing else going on in the retina.
All right. I have one more question, because I know that the brain and the eye work together. And I
Yeah.
think that my brain is really working super hard. And I noticed that when I go to bed at night and I turn all the lights off and I close my eyes, I can still see, like, literally what's there. And I open my eyes and it's exact the same shape and form of what I'm looking directly at. Is that just my brain just remembering the
That
last
may just be
thing?
your brain and having like basically like an after image. It's almost like when you have a macular disease, you will sometimes have a more exaggerated after image
Okay.
from what you're seeing, you know, when the lights are on and then they go off.
Okay, yeah, because that was annoying. I was like, okay, when I want to see, I can't, but when
Yeah,
I don't want to see, I can.
right. Annoying and concerning, I'm sure.
Okay, thank you. And thank you so much for speaking to us. I've learned a lot.
A pleasure. Thank you.
We have another, thank you, Tracy. We have another question. Last four digits, 5020. Your hand is raised and you're unmuted, so you can ask your question. 5020. Last four digits of your number.
It's Misty.
Hi, Misty. Go ahead, ask your question.
Okay. I was wanting to know because I know I have macular degeneration, but what is happening is when I look forward, I don't see people or anything, but I see ziggly lines like squirrels all over the place, and I was wondering what that is all about.
Well, that's so you're saying this only happens when you look straight ahead, or when are you noticing this?
It's mostly when I look forward, straight ahead, because when I turn my head to the right or the left, to the side, I can see people
Yeah.
when they're talking to me.
Yeah. So, you know, when we look at, I know you probably can't see it, but basically what you're describing is something called eccentric viewing, meaning when you have macular degeneration and you look straight ahead, you are trying to see through the damaged macula. And that's why you might be seeing squiggly or distorted lines, or people with more advanced will just have a grayed out area when they're looking straight ahead. When you turn your head or turn your eyes, you are using a healthier part of the retina that might be just next to the macula. And that's why you're seeing a little bit more clearly when you do that without that distortion. So that's actually not uncommon. And that's something that, you know, Elsa and other occupational therapists will often you know, work with our low vision patients to help train them to do that, especially when we find that people do appreciate having that increased clarity when looking off to the side a bit. So that's essentially that's part of having macular degeneration, is that when you look straight ahead, things will be distorted and blurry.
Yes. Okay, thank you.
You're welcome.
At this time, do we have any other questions? Okay.
All right.
Dr. Fishbein, you can move on forward.
So I'm going to talk now a little bit in our time that's left about what perhaps makes what happens during a low vision exam. And many times there's confusion from patients when they come in to see us about why exactly they were referred and what is going to be different. So when Linda gave the bio and she described kind of our practice's philosophy, which is that we do a very goal-oriented low vision exam, meaning that what we are going to try to help you with whenever possible will be directed ideally towards specific tasks that the individual is struggling with based on their vision condition and severity. So, sometimes a patient will come in and, when we're taking their history, we'll say, what are you hoping that we can do for you today? And they will say, I want to see better. And that in the context of a low vision exam doesn't really give us a lot of concrete information to work with, because anyone that is in our clinic, of course, would like to see better. That's why they're here. That's why they were referred, because they have vision that is not reaching 20/20 or some other degree of either visual field or other impairment related to their vision. So, as we're doing a case history, and most of our patients, we try to mail out a form or have them fill out a form online if we can, or have family members help them. We're really asking, what are tasks that you used to be able to do that you would like to get back to? What are hobbies? Are you working? Are you in school? What are things that you need or want to be able to do to get through your day? Are you hoping to be able, did you only recently give up driving? Are you hoping to get back to that? Were you an avid reader who read, 20 books a month until 3 months ago? Is your main thing just to be able to, handle your own finances and not rely on your family being all up in your business with your bank account? So we really are looking for specific things so that we can give a specific advice and show specific devices that are unique to the individual, because no one's the same, and especially no two low vision patients are going to have the same needs, goals, family support, emotional acceptance of where they are with vision loss. And so we really strive, even if we don't know until they get there, we really try to pull out of people, hey, here's your situation. What can we do to help? And I think that's something that's different from, hopefully it's not different from other low vision clinics, but it's certainly a lot different from what happens during a routine eye exam, where you're seeing your general optometrist or ophthalmologist, and they are, essentially giving you glasses or contact lenses that will allow you to achieve sharp vision distance and near. And if you don't have any problems, there's not a lot else to discuss. Perhaps someone for a routine exam might have a specific issue with a computer or something else. But generally it's pretty straightforward, and we're going to give a similar recommendation just purely based on what that person's prescription and vision is. Contrast that with someone with low vision, where their needs are really going to be very unique. So many times, patients will come to us and, sometimes they're really not even sure why they were referred, and they will say, I see Dr. Smith for my retinal, and Dr. Jones is my regular doctor who checks for glaucoma and cataracts. And why do I need a third doctor? And my answer is usually, well, is there things that you're struggling with? Because if there are, then one or both of those other doctors has obviously recommended you come see me, because regular glasses are just not going to cut it for you to be able to meet your needs. So kind of just moving on from that, the crux of where we start is, checking the patient's acuity. And when we measure the distance vision, one of the things that is different in a low vision exam as compared to a regular exam is really, we use charts that are a little bit different than what you might be getting elsewhere, where essentially, you have the big E, and then there's a slightly smaller E, and then a series of lines, and basically lines of letters. And basically, when we're checking the distance vision, those increments are going from 20 over 400 to 20 over 200 to 20 over 100 to 20 over 80, and then down in 10 increments to 20 over 20. So most of our patients are in that 2080 to 2400 range. And we use charts that really have, instead of having 4 or 5 levels, we're able to actually test it closer to about 10 levels. So we'll have a 2350 line, 20 over 300, 2250, and a little bit more gradation there, so that we can more easily refine a patient's prescription, is really the design with that. So, many times patients will come in, and not infrequently, they'll tell me, I'm sure my distance vision hasn't changed. My ophthalmologist checked it and has been telling me for 5 years, there's no point in changing my glasses. So, lo and behold, 2 things tend to happen. One is that there is enough of a change. It may be a small increment that maybe, the ophthalmologist is trying to be nice perhaps and save money from a patient from buying glasses, because they don't want that coming back and saying, why did you tell me to get these? They don't make any difference. But oftentimes, with a little bit more refinement and patience, we are able to improve patients' vision. The second thing that happens, not infrequently, is that the doctor's right. There is no change in their prescription. Their vision's been stable. Not their vision, but at least the prescription in their glasses that's needed has been stable for 5 years, sometimes 10 years. But you know what? Those glasses are 10 years old, and the patient's been wearing them every day, and they're scratched like you wouldn't believe. And my comment then is usually, just getting new glasses is going to give you some benefit, because you're not going to be looking through these scratched lenses. If scratched lenses bother someone who has 20/20 vision, they're also going to bother someone who has 20 over 200 vision. So, that's one of the things that we look at. The other thing is how we actually measure the prescription. So in the end, a lens is a lens, but how we're testing those lenses is a little bit different. When you go see a retinal specialist, for instance, and they measure your vision and they tell you it's stable, my experience from being in retinal clinics over the years is that, it's not the doctor that's testing your vision, it's the technician. And their job, and I would guess that they are, timed when they're too slow and berated when they're too slow. Their job is to do all their measurements and get drops into your eyes as soon as possible, so that the patient flow in these busy clinics can keep moving along. What that means is that when you look at that big E and you struggle for a moment, they may say, okay, and then let's test the left eye. And then just kind of move on. I'm sure many of you have had that experience, and they're really looking to get you tested as quickly as possible. In their defense, they're not looking to be prescribing glasses for you. They're looking to get you ready to see the doctor, so the doctor can either do a treatment or assess your eyes to make sure that things are stable or not. And the other thing that can happen, not in a retinal doctor's office, but even when you see your regular eye doctor, is when they're testing your eyes, they're using that big instrument with all the lenses. And when someone has low vision, it's a little bit harder to assess how they might be really using their eyes or using their peripheral vision or otherwise to see things the way that that individual is going to see things best. Either, as I think it was Bobby had mentioned earlier, that she likes to turn her head to see things a little bit clearer, or moving left or right or up or down with their eyes to see things a little bit sharper. In those instruments, it's harder to do that. So we typically will use, to supplement that, we'll use something called the trial frame. We'll do a trial frame refraction. A trial frame is that heavy, big set of glasses that they'll put on your face. And then we can individually change the lenses in each eye. And that also allows us to do more refinement of the prescription and many times be able to get a little bit more accurate measurement. And as importantly, really be able to truly test whether or not the patient is going to appreciate a subtle or not so subtle change in the prescription numbers. So our goal when we start the low vision exam is to help the patient achieve the best distance vision that we can, because that's always the starting point before we do anything else. So that gives us an acuity level, an idea of how the eyes are working together or not working together, if that's the case, and just exactly how sharp we can get the vision. Once we have that set, I'll circle back and talk a little bit about telescopes later, but usually after we do that part, we will move on and check the reading vision. So I'm just going to bring up, go back to my slides a little bit here. So this is often the reading card that is used in many eye doctors' offices, where there's a set of numbers on the left-hand side of various sizes. And the patient is asked to read, down the left-hand column to the numbers that are as small as they're able to. There's other digits on here which are for, people who maybe don't speak English or don't know numbers or letters, or perhaps if there's someone who's perhaps developmentally delayed, and then we can just have them tell us, are these X's or O's, or are these, upside down E's or regular E's? In any event, for most patients, we're looking at the numbers. So in a practical life, reading a number gives us a measurement that we can track, and it's useful. However, in a low vision exam, when we're looking at how is the person going to be functioning, numbers really don't tell us that information. So we may use this initially to gauge where they are, but once we start testing the reading vision, we pull out a different card. And this is the front of a card that we use. I apologize, this is really small on the screen, but these have, again, much, just like for the distance vision, these have much smaller changes between the different vision levels. And number two, it's sentences. So if a patient wants to read and all you're doing is asking them to read off a series of 4 or 5 numbers on a line, you're not going to get, as a doctor, you're not going to get the information about whether this prescription is actually going to help the patient be able to read. So once we have an idea of what the reading prescription might be, if reading glasses are indeed going to help a patient, we will pull out this chart. This is the front side, and then I don't have an image of the back side of this, but it's got, obviously it goes down in size to smaller type to where we approach even like legal size print. And again, being able to read across the line is a much different task and gives us more information. Lastly, what happens when we do prescribe anything for reading is that we will pull out either several things, but we'll either pull out a newspaper that we have in the office or a magazine, or if the patient brings in some reading material or a piece of mail, we will have them either use their glasses or magnifiers. We'll talk a little bit more about magnifiers shortly. that we're testing with them in the office to see if in fact they are able to use that or not. Because that will guide whether it's going to make financial sense for them to actually go ahead with what we're testing. Or if perhaps they will need some training with an occupational therapist or someone else to help them kind of get used to the prescription or be able to use it more effectively. So, that's a little bit about the reading vision and how we test both far away vision and reading. As we're talking about reading glasses, so the other thing that is a little bit different, and this is something that I also hear very frequently, is that a patient will tell me, oh, my eye doctor already told me that for my reading glasses, I have the highest prescription there is. And somewhere in some eye doctor schools, someone is learning and feeling like a plus 250 is the highest that can be done. And so they are telling their patients that if they have plus 250 in their reading glasses or bifocals or progressives, you can't get any higher than that. And you'll either need to suck it up or use a magnifier or some other device that they assume we will do. And some people, that is in fact the case, that those are their only options. But many times, reading glasses can be prescribed in a bifocal form up to +6 as opposed to plus 250. And in just reading glasses alone, I've prescribed +20 or even +24. Now, there are trade-offs with that, don't get me wrong, but some patients do very well with very strong reading glasses and function very well just holding things close to their face. And when we can help someone with reading glasses, as opposed to having to use a magnifier or other device, it's got a lot of advantages. Socially, it looks more normal to their peers. And functionally, it means that if they are reading or holding something, they're using both of their hands. And they're not having to read with glasses on or off, but holding a magnifier or some other device. Again, don't get me wrong, we prescribe magnifiers and devices all day long, and some people, that's all that can help. But if we can help someone by taking a little bit extra time and coming up with a unique solution for their reading vision, then we absolutely will test that. And again, we'll do that not only with the eye charts, but also with regular printed material, patient's own material. If a patient uses an iPad or an iPhone, we'll ask them to take out their device and, okay, you said you've been struggling with this, or you need to put it on maximum magnification, and that's obviously not super convenient. So let's put this on normal magnification and see if you could read that with your glasses that we are thinking about prescribing. So that's kind of where we are in terms of when we go through the first part of the low vision exam and we determine, and I'm happy to say that many times we do encourage our referring doctors to send patients to us when they are still very functional, and they might just need a little bit more time because many doctors, when you go for your regular eye exam, they honestly are too busy to spend the extra time to figure this out. And that's just the nature of healthcare, unfortunately, is that in the time that's set aside for a regular eye exam, where they're also checking your eye health, we set aside an hour for each of our low vision exams. So it gives us that luxury of having the time to really go through this with our patients. So, once we figure out, sometimes glasses alone, all we need is an updated distance prescription. And if the patient has relatively good acuity still, sometimes just a stronger than average reading prescription is sufficient. Most times it's not. And so in addition to those, we need to talk about different types of devices. So, for the reading devices, there's a whole variety. I'm showing on the screen here a magnifier. an optical quality magnifier made by a German company called Eschenbach. There's many other companies that make these. The challenge with magnifiers is that well-meaning family members will often buy magnifiers off of Amazon or other sites that many times are just not cutting it. Either they're poor optical quality, or the other thing that often happens is that they're mislabeled. So there's not a universal convention about what the term X means. So a true measure of any lens is measured in something called diopters. And X in one company's magnifier, a 5X might be completely different, even 3 or 4 times different in a different company that calls it 5X. So a 5X in one might be 20 diopters, such as the one that's on the screen now. And a 5X might be mislabeled from some other random company that really means 5 diopters, which is a huge difference. And the frustrating part of that is how often I will see a patient, and when I say, okay, let's look at magnifiers, they will say, oh, I've tried them so many times and none of them work. My first question is, well, when you say you tried them, is that something you bought yourself or did a doctor show them to you? And, usually sometimes it's, yeah, I legitimately tried them and okay, they don't work. But many times it's, oh yeah, my, family members keep buying stuff from me and none of them are ever working. And, say, oh, did you bring one with you? And we measure it. And, sure enough, it says 5X, 6X. They said this is the strongest one. And it's, half as strong as the ones that we have available in the office. So we do encourage that we do that with kind of a proper optical quality lens. There's different varieties. The one in front of us, Eschenbach, it's a German lens, super high quality, also most expensive on the market, but we do have ones that are still good quality and still do a decent job. So depending on the person's budget, we try to have them try different magnifiers. So these are handheld ones that can be used. You hold it in your hand. Usually they have lights because light is really important for the low vision population. Illumination helps with enhancing contrast. So again, when things are not black print on a white background, all bets are off and we need that extra light in there to help with that. So this is kind of a handheld one. And on the screen is a different one that's kind of something you can hold right on a paper to magnify things that way. In terms of other low vision devices to help with reading, we move into the electronic type of devices. Instead of having lenses, they use cameras. 20 years ago, the only device like this were these big computer-sized monitors with a camera that sat underneath the monitor on a table. And basically, you'd have to set aside either a separate desk or a corner of your dining room table. And they worked really well. They still work well. They still make these. But today's population tends to really prefer the portable types of devices. This one that's on the screen now in real life is approximately the size of an iPad. They make ones that are the size of an iPhone and also ones that are a little bit larger. So this is kind of like a medium-sized one, which are more the size of like a laptop computer. Many of them have a little camera that can be swiveled to enhance distance vision. So sometimes we'll use those for patients that might want to use it for playing cards or bridge or bingo even. And what's unique about this, because it's using a camera, is that it allows us to enhance the contrast. So it's using a camera. So if you're looking at a gray newspaper, it can change it into either white on black letters, white letters on a black background rather, which for someone earlier was mentioning being very light sensitive. So that's often very helpful when someone wants to read and they're light sensitive. Having that black background instead of a white background on the screen is really helpful. or black letters on a white background when you're looking at a newspaper and just enhancing print that might be just very poorly printed if for that population that still reads regular newsprint, which we'll see how much longer those last. So that's kind of the electronic types of devices. Apologize, I'm just kind of making sure I'm not missing anything in that respect. So that kind of finishes the part that I'm talking with the reading part of our vision, reading and up close tasks. So I mentioned earlier, you know, for distance vision, once we get the best distance prescription in that trial frame, then we talk about what kind of distance needs a patient might have. So for instance, students or people who are still traveling independently will often do well with a telescope lens. When patients say, wow, a telescope, I say, well, they call it a telescope, but it's really, think of it more like a miniature binocular, which is basically, you know, typically lower strength than a true binocular, but enough that it can get a person over the edge if they, you know, are perhaps, you know, taking an Uber and want to be able to check the license plate to make sure that it matches. Or if someone, you know, travels into New York or wherever and needs to look at street signs, street lights, look at a, you know, a menu in a fast food restaurant. So that's where a handheld telescope that you can hold in your hand and essentially pull up to your eyes and look through it real quickly to see something, or sporting events or things like that. I apologize again. I should have previewed these slides a little bit earlier before the Zoom, but this is a small picture of a gentleman wearing a telescope that is mounted onto his glasses, and he's behind the wheel of a car. So we do have patients with low vision. If they meet the requirements, they are able to drive. So what's unique about that type of telescope is that they're only using the telescope part to help them see street signs, other cars, pedestrians. The normal part of their vision is still happening with the regular vision. And in New Jersey, there are specific requirements for who might be allowed to do this. And aside from the requirements, the main question that we ask patients is, you know, if you had to drive looking just through your glasses, do you feel like you might still be comfortable? And sometimes patients will say, you know, oh, there's not telescope glasses, because if I had to look through my glasses for any part of driving, there's no way I would do that. We say, well, then it's probably not for you. But many patients are patients who are still driving, and frankly, they're driving when they shouldn't be. But with a telescope, it can get them to a legal limit. And not all states have that as an option, but New Jersey does. So when a patient is interested in doing that, we will get them set up with a telescope pair of glasses like this. Biggest trade-off is expense. They are around $3,000. And when someone gets that, we also will only fit them for a patient if they are going to sign up with, there's two different occupational therapy clinics that we work with that do behind the wheel training. So they'll do that either both with a patient who already has a license and just needs to learn how to use the telescope lens while they're driving, or even new drivers. So some of those patients that are teenagers that have low vision conditions but do meet the requirements for driving, they're new drivers, so they need to learn how to drive to begin with, and also at the same time learn how to drive with the telescope. One of those is at JFK Hospital in Edison, and the other one is Kessler Rehab in West Orange. So that's a little bit about telescope lenses. We also will prescribe these often for people who might want them if they're avid theater goers. They're not always so useful for television because they over magnify. So if someone's using this for television, especially with today's larger screens, sometimes we'll send them home with something to see if it's something that might work for them. And most of them will come back and say, you know, it makes faces bigger, but I can't see the whole screen anymore. So I think I'm just going to rearrange my living room so I can be, you know, 3 or 4 feet from the TV instead of 10 or 20 feet away. But theater, obviously there's a practical application there. Students, if they're in a lecture hall, sporting events, that type of thing. So that's a little bit about telescopes. This is just a different design of the same thing. This picture is another telescope. The previous one is something that's cemented into the glasses. This is a newer design that's been out 3 or 4 years that we've had good success with, that actually clips onto the glasses. And when the patient's not using it, it flips up like those old flip up sunglasses. So that's been real practical. That's made by a company called Occutech out of North Carolina. Okay, so just moving on to actually some devices that we don't use directly in our office, mostly because the companies that manufacture these have chosen to do a model where they just go direct to consumer, which is fine. That's innovation, and sometimes that's how companies choose to make a profit and sell their devices. So this is something that I'm sure many here have heard of, called eSight, rather, which is a camera that sits on a headband essentially, and you know, a patient that we see here is using it to read a magazine. Many patients will use this to watch television as well. It can be connected to a television screen so that the image is enlarged and literally, whether it's reading or distance, is right in front of the eye. Trade-off with devices like these, there's a few similar manufacturers in this field. New Eyes is one of them, and another company that's has a good market share is called Patriot. But these are, the trade-off with these is that you can't really walk around with them. There's too much magnification, you have no peripheral vision, you're going to trip and fall. So these are for stationary activities. So sometimes patients will say to me, Doc, what do you think about those eSight glasses? Can I wear those instead of just regular glasses to navigate the world? And I tell them, you know, there's a practicality to those, that they can be helpful for you, but they're really not going to be something that's going to completely restore your vision. They're for specific tasks. There's a gentleman, or I forget actually who it was, that was asking about a device that might be able to help with like reading labels or seeing money or general reading. So this is a non-optical device called OrCam, ORCAM. And this is something that clips onto your glasses. Now, many patients will come to me and won't really understand what this is and will ask for it. And my first response is that it's a wonderful device and many patients use it, but it's not using your eyesight. It is reading to you. This is really an auditory device. And sometimes patients have really good vision, relatively, of course, if they're seeing me, they have some degree of low vision, but sometimes patients are very, very functional and are kind of misinterpreting what this device is. So patients that will use this will have a range of vision. Certainly this is most applicable, especially though, to people who I'm really just not able to help. There's not glasses for reading. There's not glasses for distance. Even the best electronic digital magnification is just not cutting it for them. Their vision is just too severely impaired to be helped with anything optical. And those patients will, this is kind of another way of allowing them hopefully to remain some degree of independence, where they have something that, you know, if they are, like the gentleman mentioned earlier, if they're in the grocery store It'll read a label to them. It'll read their money to them. If they want to read a book, it'll read a book to them. If they're in a restaurant and they want to look at a menu, it'll read that menu to them. And there is definitely a learning curve to it. We are primarily we don't sell these out of our office either, but we do have a good relationship with one of the reps. And Elsa or Linda, correct me if I'm wrong, but I don't know if you guys sell this through your office or not, or if you do some training with this.
We
or
would
not.
refer them to a vendor.
Okay, so probably the same person we do. Some other, as I'm wrapping up, some other just non-optical things, is really, Linda and Elsa's group and Vision Loss Alliance has, really, they do wonderful work there. And it's just a great adjunct because there's a limitation for what we can do and what our resources are at an eye doctor's office. And so to be able to have, organizations like VLA to be able to help our patients that need a little bit more to remain independent, a little bit of hand-holding perhaps, a little bit of extra training, either with the devices or just in their vision in general, in terms of maintaining their functioning to the best of the ability, and maintaining their ability for being able to do what's called activities of daily living. So, self-care, hygiene, food preparation, safety in the house, all of those things are just some non-optical things. Computer training, orientation and mobility training. I don't know if you guys do that as well.
We do.
Good. That's great to have that resource as well. Things like in the house, marking stove buttons and, simple things that people who are new or just have never been instructed on can learn. Something as simple as, hey, if you live with a visually impaired person, don't feed them rice on a white plate. They can't see it. Get some dark plates and, figure out what food you're serving and which is going to be the best to serve it on. Just real simple things like that. So I'm just looking over my notes and I think actually I had one more slide here. Oh, okay. So I just had a slide of just a gentleman walking with a cane. So, cane training and just general mobility training is really important. And sometimes that's, I'm glad to hear that you guys do that, because I know that's, I know even like with the Commission for the Blind, ideally they'd have that full service for everyone. And it seems when I ask for that service for my patients, it's hard for them to get it. So, there's a lot of, I really hope that the optometry schools will kind of step up their game and get more optometrists that are willing and excited to provide this service. And I know that other fields like occupational therapy and whatnot, and blindness instructors are, unfortunately, we're going to need them.
Mhm.
So, that's the sad part of things. So someone's got to step up, but I think that's it for what I have prepared. So I'm happy to take more questions.
Any other questions for Dr. Fishbein?
Is anyone still here? Is everyone sleeping?
Everyone is still here, yes.
Wake up. I can go on and on sometimes, so I apologize if I went over people's expected.
The information is very valuable for everyone. Everyone on this call, very, very valuable information.
Good. Excellent.
If you don't have any questions, does anyone have any comments or questions?
Question, can you hear me?
Yes.
I can hear you. Yeah.
Okay, great. So the question is, I have a regards to that affects my central vision. It's pretty much given up on glasses because the reflection causes me not to be able to see centrally because of the blind spots, and the blind spots are not black, they're actually kind of clear because my brain is trying to fill in the space of what it's missing. So sometimes when I'm going in unfamiliar places, I'll still wear my contact lenses just so that I can get a little bit more detail to what's around me. Do you think that there are any higher prescribed glasses that might help with the central vision loss? Because I haven't tried it in at least 6 years. So I'm wondering if there's something else, a stronger lens that might help.
So we're kind of talking about two different things. So, you know, one of the things that can be very confusing sometimes for people with low vision is, you know, why can't I just get clear? Why can't I just get stronger glasses? And, you know, glasses and contact lenses are predicated. If I go back to that initial diagram, for those that can see it, but basically what glasses do is make sure that light is focused on the retina. Whether or not the retina is diseased or not, or normal, the purpose of glasses and contact lenses is to correct for what's called refractive error, meaning if you're nearsighted or if you're farsighted or if you have astigmatism. So when we do what's called the refraction for distance vision, our goal is to get it as sharp as we can, get that light. What we're doing is we're focusing that light as precisely on that macular tissue as we can. And stronger for distance, stronger lenses will not create any improvement. In fact, many times they will make things worse. Now, two things. If you said it's been some time since you had those contact lens prescription checked, then, you know, you might indeed have had a prescription change that could perhaps enhance your vision a little bit, either glasses or contacts. So if that's not something you've had checked within a few years, then it's definitely worth getting that looked at again. But secondly, would go back to what I talked about a few minutes ago, would be telescope lenses. That even though you'd still be using your central vision, you'd get some additional magnification, not necessarily to look through while you're walking, but just to help you navigate your environment a little bit better.
All right, thank you. That was helpful.
Yeah. So I think the first step is you know, basically to just get that refraction checked again and see, hey, is there a stronger contact lens prescription? Or sometimes actually a weaker contact lens, if it's been, you know, more than 5 years, sometimes actually you can be overcorrected a little bit, and cutting back on that a bit can make things more comfortable and a little sharper. So just seeing if it's changed basically is the first
I guess
step.
I'll be booking an appointment.
Okay.
We'll give
Thank
you
you
the
so much.
number. Any other questions?
Yeah, one last question. As far as astigmatism, I don't like to correct for astigmatism. I leave it alone. Is that okay?
Depends how much there is. Some people just do not. Sometimes astigmatism is a little bit tricky, and some people, even though that makes it sharper, makes their overall vision or balance more uncomfortable. So, you know, I find that it's really very individual on whether or not it's helpful. This is where, you know, what I talked about earlier, how we do the trial frame. We will, if someone, especially if there's, you know, astigmatism that wasn't there before, or astigmatism that is different than it was before, we'll put that into a trial frame and many times ask a patient, just, you know, walk down the hall with this and see how you feel. Does it feel like it's sharp and comfortable, or do you feel off balance and like this might be something you're really going to struggle to get used to, in which case it gives us a hint whether we need to modify how much or in what direction the astigmatism is working. So, yeah, it's a tough question, not knowing you, to say if it's okay. I mean, you're not damaging anything. Is it the best choice for your vision? I don't know. But, you know, not correcting astigmatism is not going to make your eyes get worse. You know, you just may not be seeing as sharply as perhaps you could be.
Oh, thank you very much.
You're welcome. Yeah, a lot of people, the word astigmatism is a little scary. So whenever I speak to a patient, sometimes I see like a look of fear across their eyes, and I'm like, hold on, astigmatism is not a disease. It's just part of your prescription. It just means, basically it means your eye's not perfectly round. And most people have a small amount of astigmatism. It's actually pretty uncommon that I see a patient that has zero astigmatism. Most people have at least a little bit of it.
Okay, and another thing, as far as cataracts go, is there an issue with not, you know, having an operation, or like can it get so terrible that you're beyond that possibility of even operating? And
Yeah. Especially if there's, I forget, were you the person who said she had pseudo exfoliation?
Yes.
Yeah. Yeah. So there can be a lot of complications with that, with cataract surgery. So sometimes they will choose not to do cataract surgery because there can be a lot of secondary complications depending on the individual. Again, not knowing you, I can't say if that's the case in your situation. But sometimes also if a cataract is left too long, it can create more issues when the cataract needs to be removed. In other words, when a cataract is removed, what is happening is that the surgeon is inserting into your eye through an incision, an ultrasonic device that's designed to basically break up the cataract. You know, kind of think of it like the construction workers when they have the, I'm drawing a blank, when they have the
jackhammer?
Jackhammer, thank you. You know, think about like a mini jackhammer. Think of it like a mini jackhammer in your eye with a vacuum attached. So it breaks up the lens and then removes all those particles. And then puts an implant in the place of where that was. There's a little bag there. They insert it into the natural bag inside of your eye. So the thicker that cataract, the longer you wait, the more destruction, the more, you know, the more force is needed to remove it. And so sometimes if someone waits too long, it's almost like, especially if there's other conditions, you know, obviously depending on other factors, the age of the patient and the expected improvement from removing the cataract, sometimes, you know, we will get some of those patients who are, you know, in their 90s with quote unquote, a pretty ripe cataract that nobody wants to remove.
Because
it has the potential to cause more problems. Either due to this, you know, in your case, perhaps due to pseudo exfoliation, or if it's very thick and would require a lot of ultrasound force to remove it and break it up.
So is it better to, if you're going to contemplate operating for the glaucoma aspect and you have the cataract, is it best to separate those two operations? Rather
I mean,
than
that's something that, not necessarily, because if there is glaucoma involved, removing the cataract is often helpful, almost like on a secondary basis. But that's, you know, you're asking me questions right now that sound very specific for your eye condition that I wouldn't trust what I'm saying specific to your eyes. You know, if you have a good relationship with your surgeon, that should be the one you're having.
Right, but there's different opinions. The reason I ask. Well, also in terms of holistic protocols, have you heard of things that can effectively help with getting rid of cataracts in a holistic
So
manner?
I mentioned earlier about too many lawyers in our country. So there's drops that are being tested in Europe that may eventually come to the US that may help dissolve cataracts.
And what are they made of? may I ask?
That I'm not even sure.
Okay, wow, sounds interesting.
Yeah,
Thank
so
you
there
very
are
much.
some places in Europe that are starting that. I don't even know for sure if they're doing clinical trials on that here. But, you know, there's buzz in the industry that, you know, may be something down the road that is going to be useful. But anything, unfortunately, anything medical in our country just has to go through so many more steps than I think pretty much anywhere else in the world. And, you know, I joke when I say there's too many lawyers, but, you know, a lot of it is just we're overprotective and create a lot of hoops to go through for innovation.
Okay, great. Okay, thank you.
Of course.
How long do you think that would take to get to the United States, to the States? I have a daughter in Germany, so I could always go over there.
I mean, realistically, if that was here sooner than 5 years from now, I would be surprised. More likely 10, 15.
No, okay. Do we have any other questions? Thank you,
Yes,
Dr. Jonathan Fishbein.
Thank
for
you
your
all so much
time.
for all of your time tonight.
This was a wonderful presentation filled with good information. Thank you so
Thank
much. We
you.
appreciate your time. Thank you for being with us.
Thank you so much for having me. I really appreciate it. And
It's a pleasure.
nice to meet everyone here virtually. And hope you all enjoyed the lecture.
Yeah,
very
absolutely.
much so.
Just everyone know that this was a very involved lecture, so it will be on our YouTube, the VLANJ YouTube channel. So if you need to listen to it again, just to capture more of that information, please feel free to do that and like it and share it. And thank you everyone for joining us.
Now I'm
for this
really nervous.
presentation. Oh,
Thanks for the warning.
Okay.
but see, it's a good thing we didn't tell you beforehand.
Right.
Thank you, everyone.
Thank you.
If anyone
thank
is
you.
interested in getting contact information to the Low Vision Center, you can contact Linda and I in the office, and we'll be happy to share that.
Great,
Absolutely.
thank you.
Thank you, guys.
Thank you, Dr. Jonathan. We appreciate your
Nice
time.
meeting everyone virtually and hope to see you.
Yes.
Sure.
Come and visit us up in Denville.
I should come see you. Yeah,
Yes, please do.
I'll make an effort to. I'm actually up there about once every 6 weeks or so.
Well,
Maybe
please
next time
come
I'll
and
reach
visit
out
us.
beforehand. Yeah, yeah.
Okay.
All
Awesome.
right, good night, everyone.
Good night,
Thank
everyone.
you.
Have
Good
a
night,
good night,
Will.
everyone.
Thank you so much.
Bye,
Good
Dr.
night.
Bye.
Night.
Thank you, guys. I'm going to sign off.
All right.
Thank you.
Good night.
Bye.